Starting Point Coaching and Consulting presents Kairos Conversations, Connecting with Quality, the podcast. Kairos is Greek for the right time, the right season, the right opportunity. This podcast features healthcare quality professionals who share their journeys, their advice, their struggles, how they made that transition into a new and exciting role. My heart's desire is that you find this podcast to be inspirational to you as you make your own journey. Don't forget to share this podcast with your colleagues and friends and rate us on whichever podcast platform you listen to. Thank you for being here. Thank you so much for tuning in today. Today, I am joined by my next guest, Tzvi Doran. Thank you so much for being here.
Thanks for having me.
Let's start by introducing yourself to the audience.
So my name is Tzvi Doran. I'm a family physician. I'm also certified in obesity medicine and clinical lipidology. I spent the beginning of my career seeing patients, practicing family medicine in a FQHC. So FQHC is a federally qualified health center, mostly geared towards treating, economically disadvantaged patients. And after that, I had an opportunity to work at a direct-to-consumer telehealth company called Ro. I did that for about 5.5 years. And then I left there and I began my consulting business called Consonant Consulting. So I started that in July of 2023. And here I am.
Awesome. So let's start by talking about how you got into medicine in the first place and then family medicine.
Yeah, it's a good question. When I was younger, I sort of always divided professions into three general categories. Those are professions that work with people. So there are many, teachers, psychologists, doctors, other kinds of therapists, physical and occupational therapists, etc. Professions that work primarily with machines. Those are maybe engineers. They could be air conditioning, repair, refrigeration, mechanics, etc. And then professions that work primarily with numbers. And I would count that professions that work primarily with money as also being professions primarily with numbers. So those are things like accountant, but they can also be mathematician or statistician, etc. And I always kind of knew that I liked the people professions more than the other two. And it was just a matter of figuring out what. So originally I wanted to be either a psychologist or a rabbi. But I guess during college, I kind of just, I was a psych major and I decided that I didn't want to do either one of those. So I sort of wandered through it. And at some point I heard about physical therapy and I was interested because I liked exercise. I liked the people aspect of it. So I did my volunteer work and my prereqs. I went to physical therapy school. And during physical therapy school, I got exposed to the hospital because I did my first rotation there. And that was when I decided that I was going to go into medicine. And then when I was in medical school, I had a little bit of a hard time sort of falling in love with a certain organ or body system, because it was still really about the people. So, it was like, am I going to specialize in the heart or the brain? These are specialties, right? Like cardiology, neurology and stuff like that. And I couldn't really settle on anything. So I picked the most general specialty, if you will, which is family medicine. You get training in pediatrics and, women's health and adult medicine. And that's kind of what led me there.
Okay. Well, it might sound like a random question, but I'm really curious. What's the difference between MD and DO, and why did you choose DO over MD?
Yeah, so in the United States, which is actually the birthplace of the DO profession, they're pretty similar. There's some small differences. DO schools still teach some what we call osteopathic manipulative medicine. Some people call it osteopathic manipulative therapy. So you learn a system of physical manipulations where you put your hands on people.
Mm-hmm.
And it's to treat all kinds of things. A lot of it is musculoskeletal stuff, but it could also be for neurologic disease and things like that. So that is a component of the curriculum. It's not the main component. And you get a different degree, right? It's a DO instead of an MD. Most of the rest of the training is similar in the sense that you're basically grounded in the sciences like, anatomy and physiology, biochemistry, pharmacology, microbiology, etc. And then you do residencies. You can pick all the same fields. The schools they have a different central application system. And I think historically there was more separation between the two fields than there is now. Like there was a lot of bias, against DOs, that they were like less than or whatever. Why did I choose DO? It was pretty simple, really. I was in physical therapy school and I had decided that I was going to make a switch. And I was sort of toying with the idea of finishing physical therapy school first. And I decided not to. And it was kind of late. So they have different application cycles also, the two schools, like the school systems. And the DO application system is a little bit later in the year. And that was what was available to me that year because I had dilly-dallied. So I applied to 4 DO schools and I got accepted to 2 of them. And I just decided to go.
Okay. Well, that's really cool. So you're a family medicine physician and you said you worked in general. When did you start to feel a shift where you felt like that wasn't working for you anymore?
The shift, I think, I was working at the FQHC. There were parts of it that I really liked. You know what I mean? I did develop good relationships with my patients, and, they were, pretty like needy in the sense that, not in the bad way. I don't mean it in that, way that's sometimes used in sort of everyday language. I mean that they actually had a lot of needs because, they didn't have a lot of resources. So on the one hand, it was very rewarding because whatever I could give them was more than what they had before. On the other hand, it was also quite disenchanting at times. Like, it was very hard to get people what they needed, and they were dealing with a lot of social problems. And I knew that I couldn't do it for like many, many years. I would get burned out. I was getting burned out even in just a couple of years. At the same time, I didn't really want to go and work at a big box, like clinic or hospital, because you become a person in a machine. Over here, at least, my patients, I was their lifeline. And I also kind of like just saw how dysfunctional the healthcare system is. I think a lot of people, would say similar things to me. So I decided to look for something unconventional. And at that time, that was when I found the position at Roe just being advertised. And I was like, you know what, let me just give this a try. I really didn't even know what I was in for, to be honest with you.
Okay, so you said the healthcare system where you felt like it was broken. Can you elaborate on that? Like what kind of things were you seeing or experiencing then?
Yeah, so the population is pretty not well. You know what I mean? I think that we're living a long time, not as long actually as many other, developed nations. If you compare us to most places in, like Western Europe, even Canada, Australia, Japan, et cetera, we actually are not living as long. But we're living, long compared to historical standards. But we're sick for much of that time. So like, the way that I picture it is like the way it should be is that people spend most of their lives healthy. And then at the end, there's a decline. You know what I mean? Most people don't just, drop dead from perfect health. But I was seeing, like people are sort of spending half of their lives sick. And I think there's a lot of different reasons for that. A lot of them are social and economic, et cetera. Some of it is also that the health system itself is not incentivized to keep people healthy. And I'm not blaming anybody in specific now. Right now, I'm just describing facts as they are. It's incredibly expensive, what we do. I mean, we spend more than twice as much, per person as most other countries that I was just mentioning that are, healthier than we are. And everybody's unhappy with it. You know what I mean? Doctors don't get to spend enough time with their patients. Other types of healthcare professionals also don't get to spend enough time with their patients. The patient is frustrated. The doctor is frustrated. You're being told what you can and can't do, usually by people who have incentives that are anything but the health of the person that you're trying to help. Be that, administrators that are not clinical people or insurance companies. And it just seems like everything is off. You're working a lot of hours and you're not getting the fulfillment that you want because all you really want to do is help people. And you can do it, but not to the extent that you really feel like you should be able to. So I just didn't see myself in that for like, I was in my early 30s. I was like, am I going to do this for the next like 30 to 40 years? I just can't see myself doing that. But I still wanted to be involved and I still wanted to help in some way. So I had to look for unconventional ways to do it.
And what ways did you find at that time?
So there were many different types of jobs. A lot of them I didn't really feel like were for me. There's a lot of jobs, believe it or not, for healthcare providers in investment, like in the financial sector. And I think a lot of it is like financial analysis, like, looking at pharmaceutical companies. Is this something that we should invest in or not? I didn't have a lot of interest in that because, as I said before, that's the numbers type of profession, and I didn't want to do that. I didn't also have a background in finance or engineering or anything like that. So, there was a lot of jobs where it was sort of like, the same old, but, a little bit better. Like, oh, we have some model where you could spend a little more time with your patients. I didn't want what I had, but just a little bit better. I wanted something totally different. So the truth is that, the first job that I applied to that was totally different was the one that I got, which was pretty lucky, if I'm honest with you. But that was the job at Roe. And that gave me, a lot of opportunities to use other skills and just learn about what else is out there. You know what I mean? And also who else is working on healthcare problems besides healthcare professionals.
Yeah, I know you said that was a little bit of luck, but can you share with the audience what steps you took to kind of get that role? Did you meet somebody? Did you have a connection? Did you kind of just apply and they were like, yes, we want you?
Yeah, so I actually did not have a connection. I applied to a job that I saw on Indeed. It was really as simple as that. The only thing I did was once I applied, like the job was, worded a little bit vaguely in that initial job description, but I knew a few things and I took a lot of time to write the cover letter. So like I made it very specific. It wasn't like generic, like, oh, just picking up on keywords. I really sort of put myself into it.
Mm-hmm.
And I think that helped. And then I met the founders, within a couple of 2 weeks, maybe they had made me an offer. I mean, there wasn't that much more to that story after that.
What did you do with that company, or can you share your workflow and what you did?
Yeah. So, I had two different sides of my job. One was the clinical leader, like I built the clinical practice. We had physicians and nurses and nurse practitioners working for us. And that side of the company was all my team. You know what I mean? So like, I recruited a lot of them, at least in the early days, pretty much all of them. I set standards for how we would practice on the platform. I did a lot of chart auditing in the beginning. I set up some education system for them to come on board so that we had some standardization. You know what I mean?
Mm-hmm.
I was also the person who I didn't myself sit on the quality assurance, like, in terms of auditing each other, but I was sort of the one that things got kicked up to afterwards. Like, in other words, like, okay, here are the results. This person seems to be, doing X, Y, and Z. Okay, you take a look at that. So that was my job. My job was also to just sort of be there for people as well. You know what I mean? Like sometimes the providers are having some issue or whatever it is. They need time off because they're having a family problem. Anything. You know what I mean? When you're a manager, you really have to be there for people. It's not. I think a lot of people don't understand that. They think that the people are there to serve you, but I really see it the other way around. You're there to serve them.
Mm-hmm.
So that was one side. And then the other side is I actually worked on the corporate side also, which was primarily working with, two teams. One was product and product design to build the clinical journeys that patients went through and turn it into a digital experience. And then also marketing, just to make sure that, our marketing was a good balance of attractive, but also responsible. So that was pretty much most of what I did, with different emphases, depending on how long I was there and how big we were, et cetera. There was different emphasis at different points in time.
I think that's so cool because it sounds like you had a wide range of things that you did. You had some operations, you had some product development and design, you had some quality, you had a big range of skills that you were using. Did you enjoy that when you were there?
I think it was probably one of my favorite parts. It's like, almost no matter what you do in terms of your medical specialty or other allied healthcare thing, you're going to really do a lot, mostly one, not one thing, but maybe, 5 to 10 things. And I really felt like I had a good variety there. I got to use a lot of different skills and also build some that I didn't even have before. You know what I mean? So that was enjoyable.
Yeah. So you were almost, I know it wasn't a consultant role on paper, but it seems like that's kind of what you were doing for them.
Yeah, I was sort of like an internal consultant, especially for the product and design and marketing people. On the clinical side, it was a little bit different. I really was functioning as the leader. But the truth is, even there, I acted oftentimes as like the medical consultant, like, hey, what do you think about this case? You know what I mean? Like as a second opinion. So yeah, I guess that's true.
Hi, friends. I have found that when clinicians decide that it's time to leave the bedside, often it's like throwing darts at a board. They just want out and will take almost anything just to move into a non-clinical role. I have always recommended taking the time to really identify your strengths, passions, and skills, and what will fuel you so that your next role is your best role. I couldn't find a tool specifically for healthcare professionals that would provide the depth needed to get a really good career evaluation. Until now. I am so happy to recommend the Stream Ahead assessment created by Career Clinic. It's the profile that I wish I had created first. Stream Ahead is thorough, comprehensive, and frankly spot on. And yes, I have personally taken it myself. I'll share the link in the show notes section of this podcast. You can thank me later. So given your work as a physician and then, working in design and operations, and you talked about some of the things that show that our healthcare system is broken, what do you think would make healthcare safer for our patients and our colleagues?
Oh gosh, there's so many places to start. I mean,
It's a loaded question.
No. It's a good question, and there's a lot of different areas. I'm not going to start anywhere in specific because I don't have like a very structured answer. So first of all, I think that we don't have good health literacy, and when I say that, I don't mean only people who don't have like a big education. I mean even people who don't. We have a lot of Googling, right? We have a lot of WebMDing. But I don't think that that is the same thing as teaching people basic health literacy, even in grade school. So, there's other things I could talk about that people don't have, like financial literacy, but like it's almost like we learn a lot of abstract, subjects. And I'm not saying that that's a bad thing, but I do think that maybe there's a little bit more place for some practical things. So I'll just give you an example. Like when patients go to the doctor or other type of therapist, they often don't give the best histories, right? They can't even really, it's hard for them to explain to you what happened, what the time course was, et cetera. And the reason is not because, they don't want to or because they're deficient somehow. It's because they've never been taught how.
Right.
Right. So that's like one example. Like if you could inform me better, I could probably help you better. Right. So that's like a super basic example. I think that another thing that we could do is unburden the system a little bit by putting a little bit more effort into keeping people healthy. Like in other words, the population that is pretty sick, not on their deathbed, but I'm saying like dealing with a lot of chronic problems or whatever is actually huge.
Mm-hmm.
And that itself is stretching the system like on a regular day. Forget about like a pandemic, just on a regular day. So when the system is very stressed, it's also more accident prone. I can't prove this, by the way, but I'm just telling you like, what I think empirically. So I think that that's another thing. I think that we have a lot of things in place that are not really part of care. They're part of like other things. So I'll give you an example. Most medical records are designed primarily to capture billing information. They're not really designed primarily for the best care of the patient. But if you think about it, like what should a medical record be designed for, right? And don't you think it makes sense that if it's not primarily designed to take care of people, then it probably is not the best at doing that, right?
Yeah, you're right. Because what I find about a lot of medical record systems, and it doesn't matter which one it is it's really hard to tell the story of the patient because you have all these different screens that you can't see everything in one place. And there's not a good flow to see the sequence of things and how they happen and the decisions that were made and why they were made.
That's totally 100% true. And I think probably, again, most healthcare providers would agree with us. And I believe that the reason is because these things are really made primarily for billing. They're made for billing and other sorts of measures that are not really related to like the best care of the person. So, like overall, I think what we're getting at is, a system in many ways that is not designed for the best care. And we could probably talk about a lot of other things too, but those are some basics. I mean, I think there have been improvements also. We shouldn't say that there haven't been, but I think that we have a long way to go.
Yeah, I think you're 100% right. And I know you said this is all kind of empirical, anecdotal. We don't have, research on this, but a lot of healthcare, to your point, is billing and insurance focused and driven. And so you're answering to the people that are paying for the services and what we think is the best for the patient as licensed, skilled clinicians, healthcare professionals is not always what the insurance companies want or need to see, or they might not even agree. Like as a physician, I'm sure you've had peer-to-peer conversations about why this patient needs this care or surgery or, whatever it is. And, you're arguing with an insurance company.
Yeah, 100%. And what's even interesting is that I think most of the big box like EHRs would say, no, but we have clinicians involved in building it. And I would say, yeah, but they're always having to like fit whatever suggestions they have into the system that's built for billing.
Right.
So
Yeah.
it's, what I mean? They're involved, but is that primarily like what it's about? You know what I mean?
Yeah, it's working within the system that they're given versus creating the system.
Exactly.
It's two totally different things. So I'm glad that you brought that up. So what are you doing now? What are you up to these days?
So, I mean, right now, I'm working for myself. I have one main client that I'm working with right now, which is a company called 2030 Health. We're building some digital tools and other kinds of tools, specifically for obesity and metabolic health. I've had some other clients, since I started this business in July of last year. But right now, that's my main gig, and I'm looking for other things as well. So that's pretty much where I am today.
So what is your business, or can you talk a little bit about who your business serves and what you do for them?
Yeah, so I'm trying to leverage what I did for the last several years, which is helping build the same things that I did at Roe, which is digital products, digital clinical journeys, clinical teams on in startups, and I've also done a little bit of sort of ad hoc consulting, just like subject matter expertise, mostly in obesity and primary care. But those are pretty much the things that I'm doing. I don't have a clinical practice now. Like I'm not seeing patients, and I don't know if I'll ever go back to that.
It's very interesting because this is a question that I get a lot from my audience. So I'll ask you as well. Did you keep your clinical license? Like, are you still licensed as a physician in the state that you live?
So I am. I maintained my licensure at my last company, especially because I was, the owner of the practice, and that some states require it to be owned by somebody who's licensed. Some don't, but I just had many licenses. Actually, I was licensed in most states in the country. Since then, I've let a lot of them go because it's very expensive, and I can't, frankly, afford so many licenses. But I maintained a few just because I don't know where my life and career are going to lead me. So I'm licensed in New York where I live, and I'm licensed in I'm licensed in a bunch of other states because some of them haven't expired yet. But I've maintained, like I renewed Texas, I renewed Florida, I renewed, I think Ohio, basically having to do with, population and also price, like how much is it going to cost me? But I've maintained licensure throughout. Yeah.
Yeah, that's what I did too. I mean, I don't plan to go back to the bedside as a physical therapist, but I worked hard to get the license and I'm kind of nervous about letting it go. So I've just always maintained it. And I think I plan to maintain it at least for the foreseeable future. And for people who are wondering, and it may be the same for you with CEs, but I can get CEs related to what I'm doing now. So healthcare quality versus having to get CEs related to, patient facing care.
Yeah, there's a lot of stuff you could do. Like even if you're working in, like healthcare AI or informatics, I think there's CME in all of it. I actually don't. I still do some general CME, like in general medical topics. I don't go as broad as I used to because I'm not seeing patients. I like usually pick a few fields and I just do that. But I think there's all kinds of ways to do it if you want to maintain that licensure, if that's your thing.
Yeah. We'll kind of just take a turn a little bit. I really believe that we're 360-degree people. And I know at the beginning of the conversation, you said that at one point you thought about becoming a rabbi. Did I hear that correctly?
Yes.
So are you able to share kind of your thoughts with that and how you're, making the decision between, okay, I don't want to do primary care with patients anymore, and I have my own business, but I still have this spiritual side that's very important to me.
Yeah. If anything, it's only grown. That's the funny thing. I realized more and more that physical health is important, but it's primarily important because it serves sort of the rest of our lives, right? If you're not healthy, then everything else takes a backseat, right? Your relationships are harmed, or at least they could be. Your whole inner world is harmed. But I realized, that desire that I had when I was younger, if anything, has only grown because, like, what I'm most interested in is sort of the inner spiritual world of myself and others, frankly. I believe that we're spiritual beings. I think that, we're not here for that long, right? If you think about it, if you live a really long time, you're talking about, 90, 95 years, maybe 100 years. That's like very few people get there. It's a blip of, it's an eye blink in history. So, that period of time is a time when we can grow. It's the only place that we have, agency and action. I'm not going to get into, whether there's an afterlife or not, because I don't even think it matters for this conversation. And frankly, I don't think too much about that stuff because I think what matters is what we do here. So, and I realized also that I think I went into medicine even for that reason. I wanted to, sort of help people grow. And I just chose to do that through their bodies. But as I left clinical practice, and especially as I worked, in a leadership position, and I sort of saw myself as there to serve the people who reported into me, this desire in me grew more and more. So when I left my job, it was time intensive, demanding. I did a couple of different things. One is I had started writing a blog, which I still write, on Substack, that is mostly about sort of personal and spiritual growth. And, I have a small readership. It's not huge or anything like that. I'm trying to grow it, but maybe it will, maybe it won't. And I actually went back and started doing an online sort of program in rabbinics, not really to turn it into my profession, just to go deeper in that area. So I'm actually doing that right now. I started only a couple of weeks after I left my job, and I do this distance program. You could do everything through the web these days. But my plan is not to practice as a rabbi. I'm just sort of trying to gain a little bit more insight and knowledge. But how I'll use it exactly, I don't know. So that's never really gone away. It's still in me.
Well, I love how you are, honoring your whole self. And one thing that I say often is the best way to improve our healthcare system is not to need it. And to your point, when we consider the whole of our being, our physical, our spiritual, our mental, everything, what makes us healthy is everything in totality.
Yeah, 100%. There's something else that I like to say, which is that pain can be anywhere in the body, and it's not always avoidable. Sometimes it is, and sometimes it isn't, But suffering happens in the mind and the spirit. Suffering doesn't happen in the body. And you can see it. Occasionally you'll meet a person that has tremendous physical challenges, but they're centered and at peace. And you always marvel at those people. And I think it's because their inner world is all right. You know what I mean?
Yeah, I mean, it's the whole of our being, all parts of us working together. So I'm definitely going to share your Substack and your website and also your LinkedIn in the show notes so that people can connect with you. And if people are interested in hearing more about your journey, they can, subscribe to your Substack as well. And some people may want to dive deeper and hear more.
Yeah, thanks so much, Brandy. I appreciate that.
So any parting words for the audience in terms of, your journey or safety in healthcare?
I guess my parting words would be two things. I'll address both of those. The audience, anybody listening, their journey is going to be their journey. You know what I mean? And the most important thing to make sure that, that journey goes well is to learn how to listen to the inner voice. I think we all have a divine inner voice within us that guides us. It doesn't tell us exactly what to do. You still have to figure stuff out, but it kind of tells you it's more of like an arrow. It's like a magnet, right? Am I in the right direction or not? You know what I mean? It'll tell you that by bothering you, right? Or by saying, this brings me a little peace. In terms of, making healthcare safer, I think we all have a part, even if you don't practice medicine or, other kinds of healthcare, or even if you're not a healthcare provider at all, you have a part because, like we talked about, different societal factors, different educational factors, different social factors. So, well, at least one or two of those is going to touch every person. And I think that most of us can't have a massive impact because we're not in the position to, but I think probably everybody can have a small impact. If you have some education, give it to somebody else. Not give it, but I'm saying share it. If you have somebody who has a challenge, you know what I mean? Do what you can to help them. Go with them to their appointment, maybe, because I think that people who have other people at their appointments, I didn't even mention this before, I think that has a measure of, it can help with safety because you have another person paying attention to things. Also, you have an advocate, right? And, so everybody has a part to play, I think. And I think that that's not so much to put a burden on people. It's more like, if anything, it gives you a little power. You know what I mean? You can do a little bit to help this.
Well, I really appreciate you for taking your time to share your journey on this podcast. And I hope that the audience has really heard the vulnerability and compassion in your story and really got a lot out of this episode. So thank you so much for being here.
Thank you. Thank you so much.
Thank you so much for listening to the show. It would mean a lot if you would share this episode with a friend or a colleague. I would be honored to encourage them in their journey too.